Thank you for attending Virtual MedicReS 2020 Good Cardiology Research Scientific Program. My name is Banu Evranos, and I'm an Associated Professor of Cardiology in Hacettepe University in Turkey. I would like to express my gratitude to the organizer of this symposium for inviting me to talk about risk scoring systems for AF prediction. I have nothing to declare. Atrial fibrillation is the most common supraventricular arrhythmia in the general population and is associated with increased risk of ischemic stroke, systemic embolism, heart failure, myocardial infarction, and mortality. The prevalence and incidence of new-onset AF is increasing worldwide with an estimated rate of 9 per 1,000 patient years. Screening for AF in the community has been proposed as an approach to optimize early AF detection and to prevent AF-associated sequelae. Here we can see the increased burden of AF by the age. So with increasing aging population, the cost of AF and AF-related mortality and morbidity will increase. AF has risk factors, many risk factors, common known risk factors. And here there's a review that shows 23 risk factors for AF. Age, male sex, smoking, alcohol intake, systolic blood pressure, hypertension, diabetes mellitus, renal dysfunction, increased height, increased weight, CRP, hyperthyroidism, directly increase the incident AF. There were inverse associations for white, non-white ethnicity, total cholesterol, and diastolic blood pressure. Non-white population is less vulnerable, less risky for AF. There are also non-clinical risk factors for AF, like surface ECG, biological parameters, imaging parameters, and genetics. Why do we need risk scores for predicting new-onset AF? The identification of individuals at risk for incident AF in the community and the opportunity for prevention and early targeted intervention might have a significant impact on healthcare costs. For people at high risk of developing AF, multivariable risk assessment for AF may identify persons who might benefit from periodic ECG monitoring for AF and aggressive control of correctable predisposing factors. Especially in high-risk patients like obese, hypertensive, diabetic, sleep apneic, and structural heart disease patients, clinical risk factors should be assessed to help identify incident AF and incident complications, its complications. Clinical risk scores may be useful to identify risk for incident AF. We have 5 risk models that I will talk about, developed for incident AF. The first one is FHS, Framingham Heart Study AF score. It predicts 10-year risk of incident AF, and the population is between 45 and 95 years old patients, and the predictors are found as age, male sex, body mass index, systolic blood pressure, treatment for hypertension, PR interval, significant murmur, and prevalent heart failure. And here we can see the points for each risk factors. And if you have more than 10 total points of risk factors, that means there's 30% probability of AF in 10 years. On the website of the Framingham Heart Study, there's a calculator, and by entering the numbers here, you can find the risk score. The discrimination of the Framingham risk score was moderately good for whites because all the patients in this population were white. However, its utility to predict the 10-year risk of developing AF in non-whites is uncertain. The statistics is 0.78. That means it's fair, moderately good. Our second risk score is ERIC score. It is formed by adding Black people and adding new risk factors, which is left atrial enlargement and left ventricular hypertrophy, and the blood pressure measurements, and race. This risk score also had points, and while the points increased, the risk increased. Then, when we compare the prediction of AF by using ERIC and FHS score, we can see that FHS score is not good in Black people, but ERIC score is better predicting both Black and white people. Then comes the third risk score, which is CHARGE-AF. CHARGE-AF had one derivation and one validation cohort. The derivation cohort was USA cohort, and the derivation cohort was European cohort. So this was the first that had both cohorts, both European people and US people. The risk factors were similar. This age and this Rotterdam study people were European people, and pooled ERIC, CHS, and FHS population were US people. CHARGE-AF was better than FHS score in both USA population and European population. And then comes the CHEST score, which tries to find risk factors and risk score in Asian people. Previously, there was no risk score for Asian people. The CHEST score includes coronary artery disease, COPD, hypertension, old age, systolic heart failure, and thyroid disease, which is hyperthyroidism. And its prediction of incident AF was 0.74. While the risk score number increases, the risk of incidence AF increased. And this risk score is also validated in Danish cohort study. And this nationwide population cohort addresses the question on clinical risk prediction for new onset AF in a population at different age strata, whereby the CHEST score may help in identifying those at high risk of new onset AF at 3 distinct age cohorts. A high risk CHEST score stratum was associated with a greater risk of new onset AF. These patients could be considered for more intensive efforts for screening and detection of incident AF. And this risk score also tested in Huawei heart study. And while added to symptoms, it showed more significant prediction of AF. The CHEST score is also tested in post-stroke patients and showed a good predictivity for incident AF. If the risk score was higher than 4, the hazard ratio was 5 for AF. The fifth score is formed by using electronic health records and ICD codes. Partners healthcare system records are used for this, and they formed 2 cohorts, one derivation cohort and one validation cohort. And the risk factors were similar. And they showed superior C statistics to CHARGE-AF, CHEST, and CHADVAS scores. The problem with these risk scores are their long-term predictability of AF. For FHS, for ERIC is 10 years, For charge AF, it's 5 years, and for chest, it's 11 years. For partners, it's 5 years risk of AF. There are also some models developed for outcomes other than incident AF. Though an attractive alternative, due to its simplicity, should be avoided, since these scores have suboptimal performance in the prediction of AF. And there are some risk scores formed in some subgroups of disorders like heart failure, and they add NT-proBNP to the risk scores, which increase the predictability of the risk scores. And there are also polygenic risk scores, which increase the predictivity of the scores. But most importantly, these novel risk factors are typically not available in large asymptomatic populations, and therefore may have limited applicability to everyday practice. Thus, rather than having patients undergo testing for biomarkers, echocardiography, or genetic tests to predict AF risk, it may be less expensive and potentially of higher yield to simply use prolonged monitoring approach. For example, a patch to diagnose AF. Then there comes the machine learning. None of previously mentioned risk prediction models are used in routine practice to guide AF screening. A key reason is that they all predict the mid to long-term risk of AF. For example, 5-year or 10-year, rather than the contemporaneous risk of unrecognized AF. To assess the likelihood of AF in the short term, artificial intelligence algorithms may help. For example, we see an ECG algorithm here, and its predictability is increased to 0.87, and it tries to detect concomitant unrecognized AF rather than predicting long-term AF risk. As take-home message, I can say that many risk factors are established to be associated with new-onset incident AF. If CHAS and CHAS-BASC and other non-specific risk scores adequately identify individuals who are high risk of developing AF, this would obviate the need to use models specifically derived to predict AF. We should highlight the perils of using risk scores for the prediction of outcomes other than for what the score was originally intended. In general, clinical scores have been less useful as most only have modest predictive value for identifying the population at risk. Automated AF risk prediction may someday be incorporated into electronic health record systems as a clinical decision support tool. Clinicians will be able to give patients individualized risk estimates at the point of care without having to perform complex calculations themselves. We can screen the general population, or we can have a more targeted approach to AF detection to focus on the high-risk patients more likely to develop AF, like elderly, post-stroke, and heart failure. I thank you for your attention.